So it's a pleasure to be here. It's a great auditorium, and I've been told that I don't need a microphone because I can project my voice very well. If anyone can't hear me, do please put your hand up. So the title of the talk I've been given is How Can Sleep Improve Parkinson's Care? And what I'm going to do is focus a little bit on an interesting problem or sleep disorder called RBD and how people with RBD dream and then later on over the next 10 or 15 years get potentially Parkinson's. So what I'm going to be talking about today is firstly, hopefully, I'm just going to give us a little bit of an introduction about what is normal sleep and what is this thing called rapid eye movement sleep behaviour disorder, or RBD. What could having this diagnosis of RBD actually mean for you if you were one of the general population? And here I'm very lucky in that I have patient videos and everybody in the videos have given full consent for this to be used. I'm going to talk a bit about the journey from dreaming to Parkinson's. I'm going to give an example of where understanding this rare condition or relatively rare condition of RBD can improve our understanding of how the brain can function. I'm going to have a think about what is the evidence that taking part in research actually improves your health. And then I'm going to end by talking about local research opportunities that there are for people who may wish to consider joining up in the Oxfordshire or Thames Valley area. So firstly, thinking a bit about normal sleep, this is something called a hypnogram. And basically what it is a graphic representation of a sleep cycle. So at the bottom you can see that this is a healthy, relatively young person who doesn't have Parkinson's or a neurodegenerative condition because they're getting a full 8 hours sleep. So they're clearly not that young to be a student who's out all night and perhaps drinking a bit of alcohol or working, studying hard for exams. And what happens as you sleep is that you start off being awake, you then go from awake to drowsiness, and then you enter the first sleep phase, which is called rapid eye movement sleep. And during REM sleep, your eyes jerk. It's very, very characteristic. If you've ever seen your baby or a child, you can actually see the eyes moving. And then as you go down towards non-REM phases 1, 2, 3, and 4, you're basically entering deeper sleep phases. And sleep phases, non-REM 3 and 4, have now been merged into one sleep phase called sleep stage 3. But basically, this is the deeper sleep phase. If you were woken, it would, you would probably be very drowsy. And it's also linked with something called slow wave sleep. So what you can see here is that you have maybe 3 sleep cycles, 3 or 4 if you're well, and that you go through these stages through the night. And then towards the early hours of the morning, the bouts of REM sleep get a bit more frequent. And if you've ever noticed that you're more likely to dream sort of in the early hours from about 3 to 6 a.m. and if you're ever woken up by the alarm, you can feel really, really tired if you wake up in a dream at 7 a.m. What happens with aging is really important because as you get older, you get given loads of other medications. And drugs have an effect on sleep staging and efficiency. You're probably more likely to get a few things like insomnia, so you might be given sedatives to help you sleep. You get lots of other conditions like pain, arthritis. All of this interrupts your sleep. You can have an increased risk of having things like perhaps depression or dementia. Again, sleep can be a very early warning pattern when the sleep starts to go wrong, that this is an early marker of something happening in the brain. And also what we call the sleep architecture, which is the ability to distinguish these different sleep phases, becomes much more difficult. And we don't know why this is, but it is a very important thing to consider. Now, I'm going to talk a bit about how we measure sleep in a minute. But what I'm next going to do is show you what the symptoms are of this rare condition called rapid eye movement sleep behaviour disorder. I've called it rare, but actually when you look at population cohorts where people have gone out and looked and done electrical brain testing, it actually affects between 1 to 3% of people over the age of 60 in the general population. So that's actually really common, and it's likely the vast majority of people don't even know that they have it, and most GPs will not be familiar with this condition. So what's the typical kind of symptom of somebody? Somebody who has this sleep disorder that we call non-REM sleep or non-REM parasomnia. Well, typically, the age at which people get this condition is over the age of 50. It tends to peak at the same age that we see Parkinson's, which is around 60 to 65 years of age. There is a male to female predominance, and typically the person who has RBD isn't aware that they've got it. It's the bed partner who notices. And what they will complain of, and they often drag the bed partner up to see their GP, is my husband talks or shouts in his sleep. He seems to be chasing something or fighting someone off. He might flail his arms. He's sometimes hit me. He's fallen out of bed or kicked a radiator. And not always, but usually these behaviours can be aggressive or action-packed. So let me demonstrate that by showing you a video. So this would not be very fun if you were in that bed. This man is having a sleep study, so he's actually in a narrow NHS hospital bed. And that's one. And I think the point being that people can have multiple episodes in the night that would repeat. And if he was woken up at the time, he might tell you he was having a dream and he could give you that recall. But if he'd gone back to sleep and then just woken up the next day, he might not recall it. Not all of these are very aggressive, so let me show you a milder one of a patient from Middlesbrough. So what you can see about these events is they're very brief. Eyes are generally closed. People don't tend to wander or leave their bed. And the attacks, if they're violent, can be quite explosive. So how do we investigate sleep disorders? Well, usually the gold standard for this would involve coming into hospital and being wired up to measure various things. So EEG is electroencephalogram. It's measuring your brain waves during your wakefulness and sleep. EOG would measure the eye movements, so that's why the electrode is just by your eyes. EMG, electromyogram, will measure your muscle activity, typically under your chin, sometimes in an arm or a leg. We also know that RBD can look like other sleep problems, so particularly problems with obstructive sleep apnea, so we measure things like pulse oxygen and movements. And this would typically be what an inpatient PSG study looks like. I've had one done. They use super glue to stick these electrodes on your head. So the day after, you can forget trying to get rid of it with a shampoo. And you have quite a lot behind you, so it's difficult sometimes to sort of get comfortable, get to sleep in hospital. And then we're working with Oxford Biomedical Research Centre to look at these home-based testing. This is our first healthy volunteer in our research. There are other ways to diagnose RBD, but they're not as accurate as the full sleep study. So these are things like screening questionnaires, which might give you around 80% accuracy, okay, for diagnosis. But it doesn't exclude these other conditions like obstructive sleep apnea, epilepsy, etc. So what could RBD, having this diagnosis, actually mean for you? And what I'd like to do here is show you a very brief video of somebody who is our research participant in our Oxford Discovery cohort. And he's really just talking about his experience. Okay. So just tell me a little bit about what brought you to the research clinic today in Oxford.
Well, today I got an invitation, and I never refuse an invitation to come to research, because one of the things the very first consultant I saw told me early on was that patients who engage in these kind of things, these research programs, tend to have better outcomes than patients that don't. And that convinced me. So every time you get in touch with me and say, can you do this, can you do that? It's always an automatic yes from me and from my wife as well.
Fantastic. And what was the sort of symptom that you'd seen the consultant for?
Originally, it was later turned out to be RBD, but I went to a sleep clinic and they videoed me overnight. And I had to put all this stuff, stickers and things all over my head. And they said, now go to sleep.
Impossible.
Yeah, well, it was impossible. But I was having a lot of dreams where I was fighting a tiger, or I'd have a dream where my boss, I'd be waiting for a lift. The lift doors would open. My boss would jump out and grab me around by the throat. And I'd be fighting him off, in my dream, but actually in bed as well, quite often clonking Alison on her head. I actually broke my finger on the bedside table.
Yeah.
And swearing my head off, not in a way that I normally do.
When you're awake, no.
No.
So very interesting. And for those pet lovers among us, I'd just like to also show you this video, which shows that RBD actually is not just a human phenomenon, it occurs across species. Okay, so this condition, just to recap, it affects 1 to 3% of people over the age of 50. It gets increasingly common as you get older. So what is the link between RBD and aging, and indeed between RBD and Parkinson's? So this is really a kind of hypothesis that I wrote with Nico Bonin, basically saying that as we get older, there are many, many drivers which will increase our individual lifelong risk. For example, to get dementia or Parkinson's. And these things can include our age, our genetic makeup, our exposure to environmental toxins, and our gut microbiota. So the gut-brain axis is becoming increasingly interesting and relevant. And maybe RBD is either a marker of accelerated aging, or it in itself accelerates the aging process. What we're starting to see is that when people have these episodes, they are much more sleepy in the day. They have much more fragmentation of their sleep overnight. What we call sleep efficiency, which is the amount of time they spend in bed asleep, reduces. And there are some changes in the EEG that I've shown you that seem to predict higher and lower risk of future progression. And so on top of that is the sleep efficiency, which reduces naturally as you get older, as I've mentioned. There's the other conditions that can get more common as you get older, which affect sleep, like prostate enlargement, pain, arthritis, restless leg, cancer. And then on top of that, in Parkinson's itself, RBD as a sleep condition is a very, very early marker. How early is it? Well, this study looked at people, 154 people with sleep testing who'd had RBD. It followed them up over around 20 years. And actually, the first feature of what we call early or prodromal Parkinson's, which happens 25 years before people get a diagnosis of Parkinson's, is hyposmia. And that is inability to smell or distinguish particular odours. Now, many of us may have had that after COVID, and hopefully it improved, but this is not what we're talking about. We're talking about a very gradual reduction that can happen 10 or 20 years, and it seems to be more specific for some odours. Then RBD happens 15 years before, and then we have other things like changes in bowel, like constipation, depression, anxiety, mild cognitive or memory issues, followed by tremor. or the motor symptoms, which can also include stiffness or a very subtle change in your ability to write or get out of a chair, or just walk along and not swinging one arm. But these symptoms, the motor symptoms, are very late, and they tend to happen about 5 years before Parkinson's. So is it real that RBD is a Parkinson's biomarker or an early feature? So many studies have been looking at this, but basically this study, which Oxford contributed to, looked at 1,280 people with this diagnosis of RBD, followed up over 5 years. And as a group, 6.3% per year converted to Parkinson's or a related condition, but that was on average. And some people had a particular constellation of what we call clinical predictors that could increase that risk by 25%. So that means over 4 years, your chance of getting Parkinson's from your date of RBD diagnosis is 100%. What we do know, however, that not everyone with RBD gets Parkinson's. So there are some people who never get it. And that what's very interesting is the longer you wait, the more people get it. But what's different about the people that never get it? So I'm going to come back now to our research participant, and he's just going to tell you a little bit about his experience of research. And how long had this gone on for until you had the sleep test?
Well, it had gone on for years and years, and I'd never really thought anything about it. It wasn't until Alison got so fed up with being woken up in the night, because I think the main thing was that I would go and do all this stuff, and then I would just fall asleep after that, and Alison would be up in bed all night waiting.
Is it going to happen again?
Is it going to happen again? Is it going to happen again? So she was the one that was kind of instrumental in getting me to see the GP who referred me to the sleep clinic, who told me I had these conditions. I had a couple of other conditions as well. And that kind of looped around to seeing one of the consultants here who gave me the news. And here I am now, a few years later, coming to all of these clinics. So and I would never miss one, ever.
Yeah. You know. How do you find it taking part in the research clinics? And you come every 18 months.
Yeah. I've actually been to more than...
You've done extra ones, I think.
Extra ones for special research that the different researchers are doing. I actually find it enjoyable. It's quite good to get a little bit of a look behind the scenes, you know, behind the curtain. What's that phrase? Penambic. Yeah. Pay no attention to the man behind the curtain. It's one of those things where you can pay a bit of attention to what's going on, because if you just turn up to a clinic, you know, you don't get anything like the same level of engagement. All the stuff that I've got from you today, it all helps me to get some idea of where I am in the whole scheme of things, which helps in life.
Yeah. So I think hopefully that's persuading you that getting more involved in research is a good thing. But what do we actually know from the evidence? Well, there's actually quite a lot of evidence. Firstly, just to clarify, research could be many different forms. What I'm talking about when I say a cohort study is just a group of people where we're just observing them over time to understand why things are changing and how things are changing, so that if we then came up with, say, a drug trial, we would actually know how to design that study and how to, you know, what kind of effect we would want that drug to have on this population. We would need to know how many people do we need, for how long. But if we just talk about cohort research, actually there's a lot of evidence that people who can get activated, which in this study is really talking about getting engaged, they get more educated, they understand their condition, they proactively manage their own condition. And as Steve has said in his video, you learn a lot more about your condition through taking part in research. And we know that that then leads to much better outcomes for individual patients in terms of their life milestones, in terms of progression of their condition. And ultimately, there's less evidence, but it does seem that costs to the NHS or healthcare also reduce through research participation. And why people get motivated to take part in research is really interesting to me, because I talk to many of our cohorts and they often tell me they don't expect that research is going to necessarily help them, but if it helps other people, then for them that's worth it. If it helps the next generation, again. So altruism is a key motivation for many people who do decide to do research. So now I'm just going to briefly cover in the next sort of 5 to 7 minutes what we're doing in Oxford. So this is the Oxford Discovery Cohort. It's an NIHR and Parkinson's UK funded project. And the Oxford Parkinson's Disease Centre, I was one of the founding members back in 2010. And we work with basic scientists in Oxford in the science area as well as the cohort. We're there to predict Parkinson's earlier, to translate what we find into better treatments for patients using animal and cell models, but also predicting clinical phenotypes or how individuals progress at different rates. So the Parkinson's cohort here, we set up in 2010 to 15, and we recruited 1,000 people with early Parkinson's from this 2.1 million population base. And the way we did it was saying, we want to get representative Parkinson's. We don't think that if we ask people to do a very demanding research schedule or travel far, we'll recruit representative Parkinson's. So we asked people to come to their local hospital, and you can see here in red, we had 11 sites, and they were known already to the GP, to the Parkinson nurse, and they could take part. So we're now following up people up to 15 years from their diagnosis. And then for the prodromal arm, which is the RBD sleep cohort, we had to go much further afield, and we're liaising here with 4 different sleep specialist units, including Oxford. We have people in the audience from that, as well as Cambridge, Papworth, Liverpool and Sheffield. And here are some of the research clinical fellows who helped me set this up. This was a little bit later, probably 2015. So what's the consequences of having RBD and early Parkinson's? We know from our study published here that about 40% of early Parkinson's within 3 years have this RBD. And this study showed very clearly that if you had Parkinson's and RBD, shown here in the hatched lines, your quality of life, your mood, your daytime sleepiness and your memory issues were worse compared to people early on within 3 years who didn't have this RBD. And this is very important because it's not just an early marker of Parkinson's, but if you have it when you're diagnosed, you can actually have a different course. We need to understand why this is. Other key findings are that people with RBD had this earlier form of Parkinson's, but they were as badly or even more badly affected than people with Parkinson's in some aspects of what we call non-motor function. So this is things like anxiety, depression, apathy, poor sleep, memory, quality of life. And if you had Parkinson's and RBD, these aspects were also worse. So this raises the question, if we treat the sleep disorder, might we actually improve these symptoms? And might we even slow down an individual progression from the sleep disorder to Parkinson's by intervening early? The answer is we don't know, but we're trying to tackle this in the near future with some trials. Can RBD help us understand symptoms of early Parkinson's? So apathy is something I've mentioned, and people who are apathetic, it's not just the sort of CBA subtype of being a student. This is basically significant problems where somebody will just sit in front of a TV for day in, day out, having previously been very active and engaged, interested, say, in seeing people. And what we found during this brain imaging study was that people who had RBD and apathy had lower levels of a brain transmitter called serotonin. And here you can see that in this red area in the brainstem in C, where it's normal, but in B above it's lower. And so we were able to show that this area of the brain in the brainstem produces serotonin, and the more severe your apathy on this apathy severity score, the lower your serotonin level was. So this is really important because serotonin, drugs that improve serotonin, might help to treat depression, anxiety, and apathy. Lastly, where are we going with trials in Parkinson's and early Parkinson's? What are we trying to achieve? From my perspective as a Parkinson's specialist, what we're trying to do is alter the trajectory from the red to the green line. And if we alter the trajectory in an earlier phase, we might even slow down or prevent somebody with RBD getting Parkinson's at all. So that to me is a definition of a cure. We don't have a cure for Parkinson's. In fact, we currently don't have anything, if you had PD, that's definitely proven to change you from the red to the green line. But any treatments we find out or test have benefit in prodromal Parkinson's are likely to benefit people with Parkinson's as well. So what's going on in Oxford? The first thing is this study. We're doing a treatment trial of a drug which we hope will reduce brain inflammation in people with RBD, and we can measure it with this fancy brain scan called a PET scan. And this trial is being funded by Parkinson's UK across Sydney and Oxford, and we're going to be launching that this spring. So we're looking for people with RBD who've had a sleep study diagnosis, and that's basically the main criteria. We also run something in Oxford called PPMI Prodromal, which stands for the Parkinson's Progression Marker Initiative. You may have heard of Michael J. Fox, who got Parkinson's very young, in his 20s. And this is his charity in the US, which is now global. We're recruiting people as well with RBD and Parkinson's to this study. And lastly, we have a registry for people who are interested in finding out more about our research. And what we have today, some of my team are here with these sheets, and you can literally scan in the QR code. It takes you to a research sign up. So actually, you can take part in all 3 studies if you wanted to. So to end, what are my key take-home points? I think the first thing is that RBD, or this sleep disorder, is relatively common, and it affects about 1 to 2% of people in the general population over 60. The research that we and others have done show that RBD is a key marker, and it's a key form of early or prodromal Parkinson's. I hope that I've convinced you that sleep matters, both to your physical health, but also to your mental health, because not having enough or having disrupted sleep affects your mood, it affects your memory function, and it can also lead to a higher risk in future of developing things like Parkinson's. We want to show in this research that early treatment of sleep problems, in particular RBD, may prevent or delay the onset of Parkinson's. And I'm proud to be part of a team for which the first ever trial in RBD is going to be conducted. So just to end by thanking the team, who are hopefully all listed here, some of whom are here tonight. So thank you, and I'm happy to take questions.